My name is Janos Filep. I'm professor of pathology and cell biology at the University of Montreal. I've just made a presentation at the 22nd annual meeting of the International Academy of Cardiology annual scientific session in Vancouver. The title of my presentation was Acute Coronary Syndrome, a role for inflammation and its resolution. Inflammation has been long recognized as an important contributor to all phases of atherosclerosis and its complication, from the initial plaque formation leading to acute coronary syndromes and stroke. The traditional view views that this focus on macrophages as driving the inflammation underlying acute stroke. Product released by macrophages, enzyme, tissue factor, contributes to thickening of the plaque and leading to activation of coagulation and thrombus formation. However, recent research imply other cells which either regulate macrophage function under this condition or independent of macrophages, that is, they can also affect these events. Among these are neutrophil granulocytes. Neutrophils infiltrate the eroded or ruptured plaques and trigger the thrombotic events. Even neutrophils are promoting monocyte macrophage recruitment to the site of the infection. Not so surprisingly, neutrophil constituents, enzyme, free radicals produced by neutrophils, or cytokines released by neutrophils have also been implicated in this process. For example, myeloperoxidase, one of the granule contents of neutrophils, that has been shown to be increased in patients with acute coronary syndrome, and elevated plasma levels of myeloperoxidase portends poor prognosis and increased risk of mortality of this disease. Over the past couple of years, that is, we have identified a self-amplifying myeloperoxidase-based inflammatory loop, which enhances neutrophil activation, promotes neutrophil survival, block neutrophil exit from the site of the injury, and thereby aggravating the inflammatory process. However, that is, inflammation is essentially a defense mechanism which has the function of recognizing infection, injured tissue, activate a tightly regulated processes governed by cytokine, chemokines, and lipids to mount an appropriate response to remove the noxious agent and restore to the normal function. Over the past 10-15 years, it became evident that resolution of inflammation is also a tightly regulated process, that this process is mediated by, predominantly mediated by pro-resolving anti-inflammatory lipid and some proteins. These lipids are derived from arachidonic acid, giving rise to the formation of lipoxins, or the omega-3 fatty acids, giving the rise of the formation of the resolvin series, resolvin E1 and D1, or the myrosin. That these lipids share some common features by targeting neutrophils, blocking their trafficking into the injured area, enhancing their apoptosis, thereby facilitating their removal by macrophages, and also blocking cytokine production. So that is a question what it has to do with coronary syndromes. In a coronary syndromes, that its recent evidence indicate that the stable plaque have a predominantly pro-resolving lipidomic profile, as to say that these pro-resolving lipids dominate over the classical pro-inflammatory prostaglandins, such as prostaglandin E2 and leukotrienes. On the other hand, over years, over a decade, that this situation changes, the amount of pro-resolving mediators decreasing, and the amount of pro-inflammatory lipids are increasing. And this is what we can observe in the plaque, in a vulnerable plaque. So that is the question arises, that is whether we can modify it, or whether this imbalance between pro-resolving and pro-inflammatory lipids contribute to the development of acute coronary syndromes. In vitro studies, there are plenty of studies showing the beneficial effect of pro-resolving mediator to blocking leukocyte trafficking into the inflamed area, blocking activation of transcription factors, release of pro-inflammatory cytokines, and facilitating removal of apoptotic cells, a critical step for resolution of inflammation. So, we have presented evidence that using aspirin-triggered lipoxin that can interfere with the myeloperoxidase-driven self-amplifying circuit and effectively reduce the inflammatory process. Other studies found that a similar effect can be seen by using resolving E1. And it is a recent study showed that is when treating animals with resolving D2 at the time when the plaque has already been developed, that is resolving D2 not only restored the ratio of the pro and anti-inflammatory lipid mediator, but also resulted in thickening of the fibrous cap of the plaque, thereby showing that, that this approach may work. So that in conclusion, that is, I have provided evidence that this inflammation drives acute coronary syndromes, the leukocyte trafficking, that it links the local and systemic aspect of the inflammatory response, and the data suggest that there is a deficient program to resolve the ongoing inflammation that is resulting in chronic inflammation or aggravation of the inflammation. It is altogether, this finding raised the possibility that by using anti-inflammatory pro-resolving lipid mediators, we can delay the development of vulnerable plaque, or we would be able to enhance the resolution of the inflammation underlying plaque rupture or plaque erosion once that this has been occurred. Thank you.